And so that first item on our list is the absolutely most critical part of the success of the community health worker. They have to be a lifelong resident of the community in which they serve and share their experience. So that when you meet someone, if you can't trace your kinship lineage in a way that other people relate to it, oh yeah, I know your second cousin, and she was married to so and so, and so you have those connections, and then you're in. If you can't describe those kinds of connections, then you're not going to be in. So it doesn't matter what kind of qualifications or training you have. First of all, you have to belong to that community. And then secondly, what we look for is someone who is a good communicator and ability to express empathy. Those first two items we can't train in people. Either they have it or they don't. So we look for that, and we don't ask for any other qualification except that they're able to read and write. Because our belief is that if they have those first two qualities, then we can train people in anything else that they might need. The other perspective here in the training of the community health workers is in that broad spectrum of what community health workers can do and do across the nation. We've taken a relatively narrow band of that by focusing on the connections to social determinants of health, like Laura shared, and also focusing on self-management skills. So in the area of self-management skills, we train them in what most people still call Stanford, although they've become independent, but the diabetes self-management, the Stanford Chronic Disease Self-Management Program that Laura referred to, which they've done classes, and not all of the community health workers lead the classes like Laura did. But the key for us is that they learn motivational interviewing skills and learn how to talk about chronic disease in a way that's meaningful to people. And then the other part of the training is we have because diabetes is such a prevalent condition that we feel that community health workers have to especially know about diabetes. And so we ask them to go through a recognized diabetes self-management education program as if they were a patient, so that they fully understand what patients need to understand in regards to balancing their blood sugars. And then another part of the training is shadowing existing community health workers so that they can actually see that dynamic happen. And then training also occurs on site as they participate in care coordination meetings. Because we work in 3 states, each state has its own resources, and then we help those agencies connect with whatever resources are available in the state. So that, for example, Ohio does have a recognition program for community health workers, and so Laura and the other community health workers in Ohio are going through that program. But they've already started their work. And so the classes for the certification are just a complement to what they do. In Kentucky and Kentucky and West Virginia, we don't have a certification, but there are a variety of local training programs that are relevant. The key for us is we start not with identifying a training program. We start by identifying what are the functions that the community health worker needs, and then those functions, then we look for the training that's available to them. We have had just excellent results. This is part of what makes it exciting for us, especially more on my end. I'm not in the home as often as Laura is in the home, and so although I hear Laura's and everybody else's stories, and that clearly is the jewel of the program, is what happens with people. But from a statistical point of view, we see a dramatic decrease in A1C, in control of LDL in the patients. And then this is what has brought the attention to the payers and is the transition here in our presentation to then talking about the relationship to the payers, because we have demonstrated to the payers that because people are enrolled in our chronic care management program and the role of the community health workers, there's less cost to them. Hospitalizations have decreased, and I'm not going to share other data that we have, but emergency departments have decreased as their blood sugars are under control. The patient need less insulin, and so the cost of medications has decreased. And as we have shared both our model and our data with the health insurance companies, it's been a little bit of a learning experience for me, because what excites me is Laura's stories and the improvement in patients' A1C. And the insurance representatives that we talk to smile and say, yes, oh, that's nice and that's great. Their eyes light up when they see charts like this one and see the decrease in hospitalizations and decrease in emergency department visits. So at least in our area, it's not just health status that draws the attention of the payers. Actually, it's more the potential for decreasing cost by sharing with them data like we have in this chart. Our experience over the last 2 years in working with the payers has evolved in 2 strategies for sustainability. And before I get a little bit more into the strategies, I want to say that we started the partnership with the managed care organizations and our state Medicaid offices at the very beginning. We didn't wait to the end and show them the data at the end and say, now fund this. It's from the beginning we have been sharing with them, to the point where for the last year and a half we have quarterly meetings with them. We give them a progress update. We talk about payment models and the possibility for payment models. And all that has emerged into 2 streams. Now, for medical providers, is no surprise. You've got the Medicaid stream, and if you're a federally qualified rural health center, then there's probably a per member per month reimbursement. There's some plans that also have shared savings programs, and then on the other side, there's the Medicare and learning to work with Medicare. With the Medicaid agencies, we know who to talk to, and because of relationships that we have, we eventually have gotten to the CEOs of all of the Medicaid managed care organizations. We've talked to the top people in Medicaid, and you can discuss model and talk about payment strategy with them, and everybody has a slightly different strategy. So knowing that we can talk with them, we have established a process of them identifying a population concentration of their members where those overlap with where we have FQHCs or rural hospitals already implementing this program, and then are discussing one-on-one with each of them a payment model and a process for adjusting their payment model over time as they realize cost savings. We're using an impact investment strategy where we've gotten grant funds, and we use the grant funds to minimize the risk to the insurance companies, so that right now we're in the process with one FQHC and one payer, where the payer says, well, in our chronic care model, our per member per month payment is $17. The FQHC says, yeah, but it costs us $85 per patient to do this. So we use that as a starting point, and we use grant money to fill the gap, but with the commitment from the payer that as they realize savings, they'll up their per member per month reimbursement until we reach that balance where the healthcare agency is covering their costs and the health insurance company is realizing a savings. So we're in the early stage of that process. On the Medicare side, Medicare is the whale in the aquarium, and you're not going to move it. We have to move. And so we have initiated a process with some help from consultants to work with the primary care agencies to streamline their care coordination process so that it is as effective as possible. And in fact, that's where I spent my morning with a consultant in one of the FQHCs, where we talked about shared patient flow forms and processes for organizing the workflow so that there's coordination among the workflow of everybody who's involved in chronic care management. And we're making the assumption that as we transform the clinic systems, then the reimbursement from Medicare increases to the point where there's enough efficiency and maximizing the billing so that there's a return in a sufficient return in payment from Medicare to cover their costs. This is not new. There are folks around the country who have figured this out, and so we're partnering with someone from North Carolina and a rural healthcare system that's figured this out, and they're helping us to test and learn how to maximize Medicare billing in order to cover our costs for chronic care management. I'm going to stop here and open it up for questions. We've also gotten some questions from folks that were sent beforehand, and maybe to get the question and answer process started. I'll start by answering one. Oh, go ahead.
This is Megan Douglas with the National Center for Primary Care. We have some questions from the people who had registered for the webinar, but we were going to go through a few questions that we had developed here within the center using the PEDAL framework to guide some of that discussion first. So for the audience, if you do have questions for the speakers, please feel free to write those questions in the question pod that you see on your screen, and we will go to those questions in just a few minutes. We're going to guide some of this discussion using the PEDAL framework, which was developed here in the National Center for Primary Care with our partner Bridges. And that framework really incorporates 5 constructs, so how organizations are prioritizing health equity, how they're engaging the community, how they're targeting health disparities, how they're acting on the data, and then to get more into that sustainability conversation, how they're learning and improving from the processes that they've undertaken. So I'd like to start with the prioritize question, and when we're talking about this, we're talking about, the funding mechanism that initiated this project, and was health equity a part of that, and some of the partners that you discussed earlier, the Appalachian Health Committee, and how health equity was involved in developing and being prioritized in this project. If you can just speak to that. There we go.
Okay, am I on now?
Yes, I can hear you.
The prioritizing process is based on a classification system that the Appalachian Regional Commission uses in order to channel federal funding to the neediest counties, and the counties at the lowest end of the socioeconomic scale are called distress counties, and all our work is in those distressed counties. In rural counties, there's not a very wide range in socioeconomic status, unlike suburban or urban areas. Uh, and, and, and so in the FQHCs in our area, for example, the vast majority of patients are either Medicaid or Medicare. There's not that many with private insurance. So in terms of health equity, it's a broad spectrum of the population that is in need.
Great. Thank you. So, and I think Dr. Crespo and Laura, you both have hit on this a little bit, and we'll have more insight here, but can you discuss how you engaged the community itself to identify how best to leverage the community health workers for this project?
It starts with the fact that the community health workers are already well connected in the community. They are known. They know the resources that are available. So in terms of, for example, in Laura's example of contact with the food bank or contact with the electric company, you know who to go to, you know where to go to. And Laura, can you say a few words here about how you have engaged the community? For example, you mentioned your church and its support.
Exactly. It has also helped with being able to engage more of the community in the fact that we are housed within our county health department. So we get a lot of people just walking in and out. And we've had so much support from the administrator here. And she is just always saying, hey, do you want Laura to come and speak to your group? And so I've been able to actually go out in the community and speak to the county retirees and to some churches and places like that. Anytime we get the opportunity to speak and let people know about this new, because it's such a new concept for our area, it has really garnered a lot of attention. And it's all been really good feedback. But every chance that we get, we're just constantly, every time we're in the public eye, we're always giving out information and letting people know about this particular project, because we also see people just off the street. We never turn anyone away. And so that has been a really big help being housed here in the health department.
Great, thank you. So just a little follow-up on that. It sounds like being at the county health department has been a huge benefit, and I want to talk about that a little bit more when we get into the sustainability conversation. What other venues or modes of outreach have you found to be most effective in informing the community, and even more so in allowing the community to inform you on their needs?
Well, go ahead, Dr. Costa.
Go ahead, Laura.
We have a really good structure in networking here, because we do have so many entities. We have the WIC office, and we have Creating Healthy Communities here, and those are just a couple of just different entities. And so we're able to kind of get out into the community, whether it be through creating the Creating Healthy Communities meetings that we have, and Get Healthy Meg. That is another forum where several members of the community, in all different aspects, get together, and we talk about different ideas on how to impact our community for the better and things like that. So we try to get involved in everything, even family fun nights and things like that. Some of our local schools, we've been able to go in there just as a health department and give out information on everything that the health department offers. And of course, the community health worker is usually at the top of that list, because it is so new and it is so relevant in our area. Diabetes is huge in our area. And so the relevancy of this program has really had a huge impact.
One of the things that the Together on Diabetes grant did was help us to strengthen the local diabetes coalitions, and it's those coalitions that organize monthly 5Ks, that organize family garden programs, school garden programs, that organize community screenings, and all that feeds into getting high-risk diabetes patients into their primary care provider, if they haven't gone before, to go there and obtain services. So, and on the output side of things, when the community health worker starts working with a high-risk diabetes patients, there are these programs that other agencies in the community have going, and so it's like an unending spiral here of feeding each other in engaging the community.
Well, that's really great. That's what I was just going to say too. It sounds like you're really integrating new approaches as they open up, and using as many multi-pronged approaches as possible. I'm going to go through the targeting health disparities and the acting on the data sections a little bit faster. It sounds like you really used the distressed community indicator and some of the clinical measures to identify those patients at highest need. Was there anything else that you wanted to talk about with regard to the data that was used in order to identify those populations that would be targeted?
I'd like to emphasize again that what has attracted the attention of the payers is the fact that we have identified the high utilizers. The health insurance companies use that phrase, high utilizers, or the high risk patients. And while a lot of people get served, because we target the high risk patients, and the data come from the primary care center, then we have data like what I showed you earlier in the slides.
Right, referring to the data that you were able to really evaluate the effectiveness of the program in order to demonstrate that use to get to sustainability, it sounds like. Great. And so let's talk more about sustainability. And I think, your last slide was really helpful to talk through some of those strategies. Can you just kind of reiterate the partners and the actors that were involved, especially to engage around some of the reimbursement, including the state, the payers, and let us just remind us of those involved as we go into this conversation.
An important part of the context here, the healthcare context in this part of the country, in Central Appalachia, is the concept of patient-centered medical home. It's for about the last 3 or 4 years, over the last 3 or 4 years, most, if not all, of the federally qualified rural health centers, the rural hospitals in our part of the country have been engaged in patient-centered medical home, and one of the keys to that is care coordination. If we would have started this 5 years ago, I'm not sure we would have gotten as far as we did. So we don't have to talk about the importance of care coordination anymore. Everyone understands it and realizes the importance of it. And so when we say, now within care coordination, you've got some high utilizers, and those are the most costly and also the most difficult to manage. And over and over again, we have providers respond to us and to their care coordination teams about patients who they've worked with for years and haven't been able to get them to improve their health status Maybe they've leveled it off but have not improved the health status. And yet the vast majority of the high-risk patients that are served in our model with the community health worker, we see an improvement. And, and, and so that ability to demonstrate improvement both to the healthcare provider agencies as well as to the insurance companies has been what has moved us towards finding sustainable payment models.
Okay. And so what is the role of the state, or it sounds like if you have been working with multiple states here, but what has been the role of the state or the state Medicaid agencies through this process?
One is that the state Medicaid offices endorse patient-centered medical home. So with the state office, when we talk about this, they say, well, yeah, it's patient-centered medical home. And so then the discussion quickly goes to focusing on the high utilizers. Similarly, with the Medicaid managed care organizations, because they're following the policies established by the state agency, then it's, again, care coordination is not something new. It's something that they all do, but we have given them a tool to do it more effectively, especially with the community health worker being a member of the care coordination team.
So are you saying that through the Medicaid agency and the Medicaid managed care organizations that community health workers would be included in the reimbursement for the care through the care coordination mechanism? And I guess what I'm trying to ask is, were there any changes that needed to be made to that program, that reimbursement for that, in order to pay community health workers?
There are two parts of that. One is that the payment doesn't go directly to the community health worker. The community health worker is paid by the healthcare agency. And right now we're using grant money to support that. What we are working at is sufficient reimbursement within, for example, their per member per month system to increase that reimbursement because of the cost savings that are realized because of what's being done with the high utilizers. So in the example I gave earlier, one of the managed care organizations, say within their care coordination system, the high utilizers, they offer a per member per month reimbursement of $17. But we have an agreement that over time, as they realize savings, they will increase that per member per month reimbursement. And so over time, we expect them, because of the savings that they have, that they'll increase it to $30 per member per month, increase it to $50 per member per month, where we, to the point where we reach that spot where the reimbursement is sufficient to cover the cost of care coordination, which includes the equivalent time for the mid-level who's part of the care coordination, the equivalent time for the nurse who's part of care coordination. They're not seeing patients, so they're not generating revenue, but they're doing care coordination. And that's the payment that the insurance companies already have. They pay for care coordination in addition to medical visits. We're just working with them to increase that payment system that they have because of the cost savings. And then the healthcare agency generate or realizes sufficient income from that reimbursement that they can then cover the cost of the community health worker, and we don't need to have grant money to cover the cost of the community health worker. The key for us has been the insurance companies saying, yes, we will work with you on increasing the payment.
Okay.
That has been a revolution for us, a 2-year process of relationship building to get them to that point of saying, yes, we will work with you on increasing the payment for care coordination for the high utilizer patients. And their interest in doing that is because we show them the data, even though the number of patients is small, but they see the number of cost savings, the number of hospitalizations have been reduced, the number of ED visits that have been reduced. And you can almost see the calculator in their brain starting to calculate, wow.
Right. I would imagine they can apply that to a much larger population that they're looking at.
As we discussed this morning, over 3 years, there's one FQHC that can claim they saved the payers $2 million.
Wow. Oh, yes. So that I could see would be opening eyes and facilitating some conversations. I would also like for both of you to talk a little bit about community health worker certification. You mentioned that in I believe Ohio, you said that they do require certification, but West Virginia and Kentucky, they do not. Thoughts on whether that is an effective policy to have, and really, we, like I said, we have a lot of states that are looking at that. So any tips you can provide in that area?
In Kentucky, the process of coming up with certification has been long and arduous. It's not an easy thing to do because you're wanting to cover everything that a community health worker could possibly do. And then, so what skills, what functions, how do they get trained? And we're not looking at community health worker in our particular model. We're not looking at community health workers doing everything. It's just these limited tasks that we have identified. So we've started discussions in Kentucky and West Virginia with the concept of certifying the agency that is doing care coordination that includes community health workers on the care coordination team. And certifying the agency to do this particular type of care coordination with the community health worker as part of the team. The response has been positive. We've also brought this up with our contact people at CMS, and while CMS does not recognize that, we've gotten positive feedback of at least keep working on it. So over the next few months, we'll be drafting a policy guide for our West Virginia state Medicaid office, to get that discussion going about certifying the agency for care coordination that includes community health workers on the care coordination team.
And just to clarify, by agency, are you referring to the county health departments or the provider organizations that are using community health workers? Yes, so that would include FQHCs and the hospitals? Okay, thank you. And Laura, would love to hear your thoughts on certification as well.
I am getting certified under the Ohio Board of Nursing presently through Ohio University and the Heritage College of Osteopathic Medicine. When we signed our MOU with Holzer Health Systems, that was one of their requirements for having the community health worker program come on board with their care coordination. And so luckily we live right next door to Athens and OU, and it's easily accessible for us. So actually, I am doing it. We have a new hire, and also our WIC director is taking advantage of this training. It is very, very informative, and I have thoroughly enjoyed it. I will tell you the truth. I wasn't really looking forward to it because it's taking time away from my patients. But I really believe that the curriculum is very beneficial, and it's going to be beneficial in the months and years to come. So, but that is really, in all truthfulness, the only reason why we are going through this training at this point, and why our health department administrator said okay to it, and is because of our agreement with Holzer Health System. So I'm very fortunate to get to do it, and I'm glad I'm able to be a participant in this certification program.
Okay, great. And so it sounds like that certification program focuses on training. So I assume you have to, pass some kind of,
Yes.
tests to ensure that, the content was provided and absorbed. Are there any educational requirements, or some states are talking about, minimum bachelor's or training in some medical, some type of medical training included. And I know, the pushback on that is really, who does that close the door to that may have those connections to the community and that value that the community health workers provide. Can you talk a little bit about if there are those requirements or what you've seen with that in practice?
There are not any other requirements other than having a high school diploma. However, in the class that I am in, most all of us have some form of medical background, and most all of us are already working in the community health worker capacity. So, so it does help, I believe, if you do have a little bit of medical background, but it is not a requirement of this program. They are actually in Marietta, Ohio. The first class that went through this training last year had a couple of teachers, and so they are working on implementing the community health worker certification program in the high school level, so that by the time these kids are done and their senior year, they will be certified also under the Ohio Board of Nursing, and that in that they will be taking their tests and having curriculum modules signed off on by their instructors.
Wow, that's great, and that's really working on that pipeline too. That's great. I want to just ask, I think, one last question, depending on how much time it takes. One of the audience questions in the registration was about benefits and drawbacks to approaching reimbursement through a disease state. So in this case, we're talking about a diabetes specific project rather than broader service provision by community health workers. So Richard, if you can, and Laura also, if you can talk a little bit about the diabetes specific versus the broader context of the larger healthcare system, please.
Yes, we started working with diabetes. The original grant that we got 7 years ago now, it was specifically for high-risk diabetes patients. We've continued to use diabetes as the start for working with the health centers to organize their chronic care condition. However, in our experience with the health insurance companies, they do not have payment models that are disease specific, especially when you think of a per member per month payment model that most FQHCs, federally qualified rural health centers, receive. The payment is the payment is adjusted to what what the health insurance company is able to pay, and that is, and for high utilizer patients. And so we have evolved from looking at diabetes to working with the health insurance companies to identify who are their high utilizers. And of course, diabetes patients are included with that. And so we're in that transition point right now of expanding the patient population that's served by our care coordination model to include what the health insurance companies identify as their high utilizers. So we're in transition right now.
Okay, and I think I also heard you mention earlier with some of those bundled payments that may be specific to certain conditions, you're able to leverage some of the payments from those bundled payments, but it sounds like you're thinking a lot broader than those specific diseases and really how within the larger health system the community health workers can benefit the patient population. Laura, did you have anything to add?
No, I think that
with that?
That Dr. Crespo covered all of that.
Okay. We are running out of time. I want to thank you both so much for sharing your experience and responding to these questions, and we hope that it is helpful for our audience who are national and working on developing community health worker programs in their states. So thank you also to the audience. A few email addresses here if you'd like to reach us here at Morehouse School of Medicine, or follow us on Twitter. And also just want to remind everyone that we'll have another webinar in this series focusing on home-based intergenerational diabetes prevention and management programming for Native American youth with the Johns Hopkins University on July 19th. You can visit our website, diabeteshealthequity.org, to register. And that's the conclusion of our webinar today. Thank you, everyone.